morning. How's everybody? I'm a physician, and I'm trained in infectious diseases. And I kind of turned a corner about 15 years ago and began to work on this topic of violence. And I'm going to talk today about violence redesigned. After my training, which was in infectious diseases and in San Francisco, I took the leap to move to Somalia, where I lived for 3 years. Along with 5 other physicians, we were charged with the job of working with 1 million refugees in 40 camps, 6 doctors. And this is how I basically learned, as all of us did, is how to use new categories of workers for reaching people. These were health workers and traditional birth attendants and so on. And this is also where I learned how to prevent the spread of things that are known to be infectious diseases like cholera and like tuberculosis, and those were in fact my assignments. And I spent 3 years living in Somalia and then got picked up by the World Health Organization. This is not their headquarters. And they assigned me the 15 countries in the middle of the AIDS epidemic, Uganda, Rwanda, and Burundi, and Kenya, and Tanzania, and Malawi, and so on. And I spent 7 years working on that, and the last 4 running this intervention development unit, which consisted of 40 people, 38 from countries other than the US. In Uganda is really where I learned how to do behavior change, and we had a very successful program in Uganda, in fact the only country in Africa that reversed its epidemic. After about 10 years straight living in difficult circumstances, I decided to come home. It was overwhelming to be away for that long. But what really separated me from the people who were there was not just the differences in poverty and things like that, but it was that I was actually able to leave. So I came back to where my parents were, but didn't really know what I would work on. Because to me, having been away from America for 10 years, I didn't really see that there were any problems here at all. In fact, I saw that everybody had water that came directly into their house. How many of you have that situation? And in many homes, in 2 or 3 rooms. And I saw that people would just kind of change their thermostat just 1 degree or 2 degrees to make it a little bit warmer and colder. And I do that now. But I didn't really know what I could possibly work on. But friends of mine began to tell me about children shooting each other with guns. And I was asking people, well, what are you doing about it? And there were basically 2 things that I heard. I heard about punishment, and I heard about a whole host of other issues that needed to be solved. I called this the everything theory and the punishment theory. And we'd heard the everything theory also for tuberculosis and for diarrheal diseases and so on, but we had learned in infectious disease control that you can sometimes narrow down and make these changes. And I felt that something was possibly missing, which might be called science or a scientific understanding of the problem, which frequently comes to a new approach. And so I began to look at this kind of inquisitively and see some patterns, such as this kind of clustering of killings and various types of curves that were familiar to me, and this was unconsciously kind of seeping in. It struck me that it was possible that we had the wrong diagnosis on the problem, which is really kind of my world, where I'm coming from, is that you really have to spend a lot of time trying to figure out what is really going on, which tracks back to our own history. And this is a slide of a painting of plague from the 1400s, fairly recent in the history of man, actually. But at this time, still, we didn't know what was going on, and people were dying. We didn't want to go in their neighborhoods, and we were blaming the people and had all kinds of bizarre responses to them, including putting them in dungeons and tracking widows around the moat. And why were we doing these apparently wild things? Is because we didn't know what was going on at all. And why didn't we know what was going on with plague? Well, it was because it was due to an invisible microorganism inside a flea, inside a rat. Nobody knew it was invisible. And so we were using these kinds of responses until about 400 years ago, someone designed a microscope and found these things. But it took another 200 years till someone else, Pasteur, discovered that they did anything at all, primarily something that inhibited the healthy growth of beer and wine, and he made money as a consultant to these industries. And then about 20 years later, the real hero, Robert Koch, figured out that these invisible critters that we didn't know anything about for most of our history were causing these massive epidemic diseases. And in fact, it was only these great infectious diseases and violence that had been killing man in the tens and hundreds of millions for all of our history. All of these disease processes got linked to these invisible organisms, and all kinds of redesigns happened. Bed nets impregnated now being used for malaria, hand washing, all kinds of innovations, case finding and treatment, early detection, all kinds of new systems that now keep us healthier. So we thought maybe looking at violence in a new way could also bring things into the past, just as these great infectious diseases had been put into the past. And so we began to inquire as to if this were a contagious process or a contagious disease. We might say yes because of these reasons. First off, here's the definitions. Contagious, all that's required in the medical definition is that it's transmissible. Well, it turns out that it's the #1 risk factor of whether you do violence, whether you've observed or witnessed or been exposed to violence, just like it's the #1 cause of whether you get flu or a cold, of whether you've been exposed to flu. So children who have experienced violence, let's say what is called child abuse, they're more likely to do child abuse as an adult. Well, just think about that. Why would you do that? Don't you know how bad that was? But it's because something was transmitted. And we know about the transmissibility when we look at retaliations or gang wars or even wars. And as it happens, the actual medical definition of disease itself is actually completely fulfilled in that there is a disorder of function of an organ system with characteristic signs and symptoms that cause morbidity and mortality, which means that it can land in hospitals, it can cause you to die. And so both the medical definition and the general public definition of disease is also met. And you might be aware that the Centers for Disease Control has a center for violence prevention, as does the World Health Organization. So if you were going to look at this scientifically a little bit, we just say, well, what are the characteristics of a contagious disease? And then we would want to test theory. And the characteristics are very clear. You need clustering, and you need epidemic waves, and you need to be able to show transmission. And all of these are fulfilled. This is the clustering, absolutely typical of everything I've been looking at in my career with infectious diseases. This is the clustering of cholera in Bangladesh, and here's the clustering of killing in Chicago, indistinguishable. Here is the epidemic curves of an infectious disease. This is a cholera epidemic that I was involved with. You see the standard epidemic curve, and you can also see this wave, the secondary wave. The secondary wave means that there is a new population that got newly exposed. In this case, since this was cholera, it was a new group of refugees that came into that camp, and so there's a new epidemic wave. Make sense? Here is a curve of violence, looking very similarly the standard point source epidemic curve, and you see a secondary wave. Here's a group of people in Rwanda who were hiding, who were found. Susceptible, exposed, and an increase. Standard epidemic curve. And then the curve consisting of many curves, because every epidemic consists of many epidemics. And this is the US curve of violence over the last several decades. The most important characteristic, of course, is transmission itself, which is that violence leads to more violence, which we see in soccer riots, which we see in the Arab Spring, which we see going on in Syria now. We see it occurring in families. And so, like I say, if you're exposed to a cold, you're more likely to get a cold. Not everybody will get it, just like being exposed to violence. Not everybody will. And there's differing incubation periods. TB you'll get decades later. Flu, TB, and violence, you're exposed to stroke? No, you're not more likely to get it. Exposed to someone with a heart attack, not more likely to get it. But exposed to, observing, witnessing, or being traumatized yourself directly by violence, more likely to do it. In fact, let me put this one in front of you. If you're an Israeli child exposed to violence from Palestinian side, or a Palestinian child exposed to Israeli violence, guess what? You're not only more likely to do violence in the more obvious direction, but you're more likely to do violence also within your own community and to your own family. How does that make any sense? Something was transmitted within the brain. And so we see also that being exposed to community violence causes you more likely to be exposed to do suicide. Exposure to family violence makes you more likely to do community violence. Being exposed to violence as a young child causes you more likely to do all kinds of forms. So what we're seeing is actually transmission across syndromes. So these are different manifestations of perhaps the same overall disease process. And we now even know some of the means of transmission, and I'll just take you through this very quickly by comparison. But it's very interesting because we know how cholera gets in. We know that it comes in through water or food. We know likewise now that violence comes in largely through observation or witnessing, but also from having been victimized. So there's a ton of statistical information on this. But it doesn't just happen automatically in either of these cases. There's what we call processing. In the cholera situation, your intestine actually interacts with the bacteria, changes itself to put out more of the cholera itself in the form of diarrhea. There's inhibition of the way that salt and water is handled. Similarly, we're now learning that there's cortical processes, dopamine-mediated processes, and also processes that have to do with your emotion system that call hypervigilance. And so, what are you looking at me? There's cortical processes involved in copying, social following, avoiding social isolation. This is all mediated by either dopamine or pain centers. Being traumatized causes you to go off more quickly. And this is all reviewed now by an Institute of Medicine report. So in other words, how are behaviors formed? Ever wonder? It starts like this. And this makes a lot of sense, and it's evolutionarily advantageous, and it's unconscious. Behaviors that don't make sense even are copied. And that's the cortical processes. And then you have the whole idea of doing what other people do. And this is also unconscious, but possibly the most powerful, invisible force. The principal predictor of whether someone uses a condom is whether or not they think their friends use it. But it's not what they would tell you if you ask them. These kids, it's expected of them that they would fight after school. It's also socially accepted of the others that they would be the role of someone who just watches. These are social expectations. By the way, I think there's a social expectation of sitting in your seat now and not talking. There's no one like jumping up and dancing. There's a social expectation of how to dress today, which I partially conform to. And when I was in medical school, I should tell you that when we were watching angiograms, a third of us were smoking. But now if someone were to light up, what are you doing? The social expectation is different. We don't even think about it anymore. And then the last aspect of this, besides the copying and the social following, which are all contagious processes, is going off faster. And that is actually trauma, and that's injury to the brain. And this all builds into the collective nature and the epidemic. So what we've decided to do is actually to look at how epidemics are really reversed, which we know, and do a redesign, following this rediagnosis, and treat violence as a contagious disease. And so if we think about it in this way, in which violence is just spreading one person to more, one group to other groups to other groups, then what we need to do is to break up the transmission, detect and interrupt events, and then prevent other events from happening, knowing about where they might be brewing, and then shifting the norm, just as we've shifted the norm in this group from not smoking. And so we use different tools for different types of epidemics. For TB, you have to treat a very contagious person. For this particular problem of violence, you need to detect and interrupt people who are about to shoot, which means you have to find them just like you might need to find a SARS case or first case of bird flu or something like that. You need agents who are detectors, who can serve as interrupters, and then you have to find the next group and cool them down. And this can be done systematically through new categories of workers. And the first new category of worker is what we call violence interrupter. So following mapping, and these are people who are on the street, professionals, paid, carefully selected, trained, supervised, supported, work documented. They've been shown to be 100% effective at preventing retaliations in the context of a murder in 5 communities by independent evaluation. So you look at these guys and realize that they are credible, trusted, have access, they're trained into talking to someone for their own benefit, they know how to cool someone down, how to buy time, how to reframe, talk to them about their kids, talk to them about their parents, and show them that they're socially safe as well as physically safe to not do it, and then we stay with them for months. This detection and interruption also occurs hospital-based. And then the next level of work is the work of working with people for a longer period of time and finding out the others in the neighborhood who are also at this very, very high risk. And this category of worker is a behavior change agent, sometimes known as an outreach worker. They're actually health extension workers too. And they work with very high-risk people, breaking it down as to what the categories of conflicts are: girlfriend conflict, money conflict, disrespect conflict, modeling new responses. And then the last part of this is really shifting norms. This is what we in health do, is about changing behavior, changing its eating behavior, exercise behavior, smoking behavior, sexual behavior. It's just violent behavior, just a behavior. There's a whole category and list of things that are involved with this, which is basically has to do with multiple messengers, especially the most credible messengers. This is the most visible aspect of it, is the community doing a response to every shooting. Public education campaign, and a new set of norms. And this becomes a system. It becomes an epidemic control system, like a tuberculosis control system or a sexually transmitted infection disease control system that are usually invisible to the public. Health departments are now beginning to manage. Health departments in New York City and Kansas City and Baltimore are now managing this system of controlling and reducing violence. So this is re-diagnosed now as a health issue because it's a behavior issue, besides the fact that it now can be classified easily as a contagious disease. So the first time this was tried in the worst police district in the country, which was in West Garfield Park in this city, we got a 67% drop in shootings and killings. That has been, this is after 5 years of design. And then we got money from several sources and said, ready, set, go, let's try it. And then everyone said, well, do it again. And so the next neighborhood was Logan Square, and this is the result there. You could see shootings and killings per month, and again, the drop. There's actually a doubling in the drop when we doubled the number of workers. And so all the way to your left are a compilation of 6 neighborhoods, and then the other 3 are 3 sets of controls, multiple neighborhoods. So this isn't 4 neighborhoods. This is 6, and then 12, and more than that in the whole city. And so there's statistical evidence in the first 6 neighborhoods averaging a 45% drop in shootings and killings. And then the next 4 neighborhoods, again, showing reductions. In the next 4, before and after hotspot density mapping, and a whole bunch of statistical work has now gone into the analysis of this, including, as I'll show you, independent evaluations. This is when ceasefire, which is what it was called then, and some people know it as, was tripled years ago. This is when it started. 1 neighborhood, 5 neighborhoods, 15 neighborhoods, continued without any additional change in coverage. Funds interrupted 50 additional killings, 400 additional shootings.
Newspapers were not happy. Funds were restored and continued at that same level, and then a recent interruption again. And these are projections with full coverage. This is just Chicago. So there have been 3 independent evaluations. These have been extremely extensive. Justice Department, CDC, Hopkins, 100% drop in retaliation murders. In 5 neighborhoods, 2 other neighborhoods, 50% drops. This is a summary of the study done by 4 universities, 7 years of work, 10-year baseline. The Justice Department throwing everything they had in terms of different types of methods of analyzing. Baltimore, which was the first replication site, Cherry Hill, 56% drop in killings, between 35 and 55% in 4 neighborhoods. This is showing the stoppage of these very high spikes and more months of 0. This is now being used in Latin America and in Africa and in the Middle East. So we're getting about a 56% drop in the first place where it's been applied in Puerto Rico. It's now active in Honduras and in Colombia, in San Pedro Sula, which is the most violent city outside of Syria now. 70–80% drops in the Cape Flats in South Africa. We're involved in reducing the violence in the last Kenya election. Cell phone technology was used as extenders to reduce rumors and to do detection. And I don't know if it really was effective on interruption or not, but this was our first real experiment with really adding the cell phone piece. We've been working in Iraq, and particularly in Basra, for about 6 years, and 2 of my staff just came back from the Syria-Turkey border, where we've done some training with some of the groups and individuals in preparation for what might turn out to be sectarian violence there. There's been a lot of attention to this work. The New York Times did a cover story a few years back on the idea of this as a viral or infectious process. The Economist a few years ago called this the approach that would come to prominence. There's been a movie made about this. Some of you may have seen this. These are the cities that this is working in, including Philadelphia and New Orleans, New York, Baltimore, Chicago. The international work is really taking off because there's kind of a different idea, a different mindset in the international world. They're very eager to be rid of this problem, actually. So here's the new idea. It changes our thinking about this problem. The text here is intentionally medieval. To consider this problem as a problem of bad people when it's clearly an acquired, contagious process involving the brain, and in which the responses to this need to be more modern, including interruption and behavior change and norm change, which are not theoretically effective, but have now been demonstrated in about 15 sites by 3 independent evaluations. It also gives us the opportunity to develop a new language about this problem, forget the words that are commonly used, and begin to think about this in terms of transmission, behavior change, social norms, social pressure, interruption. So violence is a disease. It's a disease state. This is more than a metaphor, a redesign based on a rediagnosis. This has been scientifically demonstrated to be effective now. So this is beyond idea, beyond pilot, beyond replication. Health departments in cities are taking this on, and hospitals in cities are taking this on. And the behavior change community are getting involved with this and taking a much, much larger role. We're trying to move this field from wherever it is now conceived and managed into the health sector. So the possibility then remains, as it has been for many of the infectious diseases, that we could put this problem, we can put this problem into the past. I guess you'd have to end here by saying with redesign. Thank you.